Okay. We're here today to talk a little bit about managed care and how managed care might have some implications for persons with disabilities. And also a part of managed care is that of privatization. There's been a lot of discussion recently on having private sector manage public sector health care, for example, Medicare and Medicaid. And there are consumers with disabilities who utilize both of these. So there will be some intermingling of the discussion about managed care and about privatization. First of all, let's identify or define what it is we mean by managed care. And I think with insurance systems today, we all go through some kind of managed care system. But in the broadest sense, what managed care is basically, it's a formalized approach to medical services in which there is a predetermined or pre-selected group of physicians and or hospitals within this delivery service in which you as a consumer or an enrollee will have to go through in order to get your health care services. Physicians also, as the service provider, must enroll just as you as the patient enroll in the managed care system. Now, the managed care system has three core concepts related to it. And the first core concept is cost containment. That seems to be the buzzword now anyway. Whatever we talk about, everybody's concerned about cost. So cost containment simply means that there is a specified fee for services. The second core concept related to managed care is control of utilization. And what we mean by that is that as a consumer, you will be granted a specified number of visits for certain types of services. For example, if you're going to physical therapy, if you're receiving psychiatric counseling, within the managed care system, you will receive X number of visits within that given coverage year. The third core concept of managed care is that of limited information dissemination. And what we mean by limited information dissemination is that the information is shared within the network of service providers, and so it's not a whole host of exterior factors that you would have to send this information to. It's only those service providers within the network. And the interesting thing about this is even as a patient or a consumer within that system, you may find sometimes when you request your own medical information, you have difficulty getting that medical information because that information is the property of that managed care system. And so those are the three core concepts: cost containment, control of utilization, and limited information dissemination. There are different types of managed care systems, but there are three commonly known types. Probably the most commonly known is the HMO, or the Home Management Organization. And within the Home Management Organization, this is where the individual receives specified health services for a fixed premium. So within that system, whatever service you're going to utilize, there's a price tag attached to it. The second type, or most common type of managed care system, is the PPO, or the Preferred Provider Organization. And within the PPO, consumers are referred to specific doctors or specific hospitals in which they receive services at a discount. So that's the PPO. And the third type is the PSO, and the PSO is the point of service. And the point of service simply means that as a consumer or a patient within that system, you are assigned a primary care physician within that network. So HMO, PPO, and POS are the most common types of managed care health systems that we see. The thing also to remember, the PPO and the POS, okay, these acronyms are getting to be fun. So the Preferred Provider Organization and the point of service will allow the patient or the consumer to pay an additional fee to see a physician outside of the network. Okay? So you have that option if you want a second opinion, and that second opinion may be from a physician that does not belong to that network, and you can pay an additional fee in order to get that. With HMO, if you want it, it's totally your responsibility to go outside and get that second opinion, and it's not going to be a negotiated fee or reduced fee for you to go outside and get that second opinion. But with the PPO and the POS, okay, there is some negotiation where there's a set amount you can go outside to a provider outside of the network and pay what that specified fee is. HMO, you can go outside on your own, but you have to pay whatever the full amount is. So it's kind of like the basic difference there. I mentioned earlier about privatization being an issue that's linked with managed care. And simply what I mean by privatization is where publicly funded services are being provided by non-governmental entities. So someone in the private sector would be the administrator of public health care programs such as Medicaid or Medicare. And there are advantages and disadvantages to looking at privatization, especially as it relates to individuals with disabilities. And what I want to do first is talk about what are some of the advantages of privatization for managed care health services. Now, the disadvantages are a little bit different, so I'm going to kind of separate disadvantages of managed care and privatization. But first, we'll look at the advantages for privatization and how this may be of advantage to persons with disabilities. So let's take a look at the overhead. And the first major advantage is lower out-of-pocket expenses. And that is simply because there is a fixed premium that you pay, and then there is a fixed fee for the cost of that service you're going to get. Now, keeping in mind when we talk about people with disabilities, and we're talking about individuals who will have chronic conditions, individuals who will have severe conditions, and individuals whose level of service will vary depending on what's going on with the condition. Okay. The second advantage to using the managed care privatization is less paperwork, and we can all appreciate less paperwork because keep in mind the information is shared within the network. So that information is readily available, and there's less even the reproducing of information. So we have to deal with less paperwork. And paperwork in the sense, not so much that it's actual paper since everything now is computerized, but even dealing with a computerized system, there is less entry of data that you actually have to deal with. The third major advantage is more comprehensive benefits, including drug coverage. Again, keeping in mind, if you think about the different types and even the number of medications that an individual with a disability, particularly someone with a severe disability, may have to use on a daily basis, and with the drug prescription being a part of that coverage, and certain types of drugs may still be excluded from coverage, which presents another difficulty. But because you get a more comprehensive package that includes drug or prescription coverage, that's one of the advantages to the managed care system. A fourth advantage is a focus on prevention. Now this one may be debatable. It may be debatable because I want you to kind of think back to the last time you probably went in to see your physician, whether it was just a routine visit or a checkup, or you went for a specific purpose, and think of the conversation you had with your physician about what's going on and what are your options. And if a part of what we're trying to do with managed care is prevent things, or at least minimize the effect of something that has already happened, and you may not get referred to the next level. Now, how does that help reduce or prevent? But supposedly within the system, the focus on prevention is an advantage. Okay. Sometimes it's arguable that, yeah, we're focusing on prevention. A fifth advantage of using managed care is the continuity of care. Because, again, you're working within a network, and there is rapid communication, supposedly, that takes place in relation to a patient, and because you're dealing with that network or that system, your physician is more readily able to access your information. That physician is maybe assigned to staff at that particular hospital within that network. So there is some continuity of care. Those specialists within that network, so there is not the fragmentation that may occur with other type of healthcare programs or healthcare systems. And we know for people with disabilities, the continuity of care becomes a crucial issue, not just in the quality and the continuation of care, but in the timeliness in which the individuals receive that care. Okay. A sixth advantage of using the managed care system is increased flexibility. Now, exactly what we mean by increased flexibility is debatable if you ask the consumer or the patient or if you ask the physician. But a part of what we mean by increased flexibility is simply that as a consumer or as a patient within that system, you have several options in relation to treatment. Okay, again, these treatment options are going to vary depending on the cause or the etiology of what it is you're dealing with. But we're looking mainly at what are your options to treatment within that network. The seventh advantage to managed care is reduced costs. Okay, this kind of links back to the fourth one of the focus on prevention. You know, if we can prevent certain things, or at least if we can minimize certain things, then we should be able to reduce the cost of the overall treatment program. And also because we have fixed fees, because we have predetermined amounts, then that reduced cost is a benefit to the network and supposedly will trickle down to the consumer. Okay. That's supposed to be another advantage of using managed care. An eighth advantage of managed care is increased ability to provide locally based services. And this is going to vary depending on where you're located. One of the major problems of healthcare in general, especially in relation to rural areas, is, well, we may not have services available in the local area, so people still have to travel to get to medical services. But with the managed care, and because we have the network established, you have the increased chance of getting better access to local-based services. But again, it depends on where you are, what's available within that network. And if it's not available within that network, this really does not become an advantage to you. Okay? The ninth advantage of using a managed care system is the avoidance of duplication. And again, this is duplication of services as well as duplication of paperwork or data. The 10th advantage is the ability to provide specialized services, because specialists are a part of the network as opposed to those who may only have access to a general practitioner. So you have the advantage of having specialists within the network, so that, again, it's supposed to increase the opportunity in terms of treatment options. Okay. The 11th advantage is improvement in consumer and advocate relations. And what we simply mean by this is that the physician, or at least the network of service providers, act as advocates for the consumers within that particular system. Okay, again, this may be an arguable point coming from the consumer's perspective if this actually happens, especially when we look at stuff like cost containment, where you don't get to see a specialist because we can keep the price down. Or if you have a specialist and you no longer see that person because it's been decided that maybe your general practitioner is a person who can provide that service and you don't need to see a specialist. Okay, so in that sense, advocacy may be arguable. Okay, but in an ideal situation, the focus is, well, the service providers within that network can advocate on behalf of the consumers or the clients within that network. Okay, and the last major advantage is, and this is strictly an administrative advantage, is the decreased need for permanent staff. Okay? Okay, how does that imply or impact on people with disabilities? And we know that based on what it costs to run an operation, as a consumer, no matter what service you're purchasing as a consumer, if it costs the organization to administer a program, as a consumer, you're going to feel the impact of that cost. So from the managed care perspective, if we can provide services without having a large number of permanent staff, that's supposed to be a cost-saving factor. That, again, is supposed to trickle down to the patient or to the client. And supposedly, you will see that in your premiums. Okay. Again, I think with what we've been seeing lately in insurance, people will argue that point as well, that this, well, I don't think this is an advantage, but it is at least an administrative advantage. Okay. So those are the major advantages of using managed care. Now, there are disadvantages for managed care and privatization. And so what I'm going to talk about now is those disadvantages. And the disadvantages for managed care are a little bit different than the disadvantages for privatization. So I'm going to talk about those separately, those disadvantages. And first we'll deal with the disadvantages of managed care. And this is a much shorter list, so I'm not going to present you with an overhead on this one, and just tell you what the disadvantages are for managed care. The first major disadvantage for managed care is that the consumer or the client, the patient, is unable to continue seeing his or her current physician if that physician is not a part of the managed care plan selected. Okay? And again, depending on where you are, particularly in rural areas, this could have significant implications. You've been seeing this physician now for 10 years. This physician is very familiar with your condition, but now you've joined an insurance plan, and this physician is not a part of that plan. You can no longer see that physician as a part of the plan. If you want to pay for it separately, you can continue seeing that, but most of us can't afford to do that while we're paying an insurance premium and then paying out of pocket simultaneously. So that's a major disadvantage is if your current physician is not a part of the plan, you're going to have to find a new one. You can't continue seeing that physician. A second disadvantage of the managed care plan is that a consumer may have more limited access to a specialist, especially if the primary care provider must authorize that visit to the specialist, and also if the primary care provider receive, and this is not uncommon, receive financial incentives to reduce referrals to a specialist. And we kind of hear of this all the time, where the physician or the primary care physician then says, I will treat the condition and you don't have to see a specialist. And there are incentives for that primary care physician to not refer you to a specialist. So that's one of the disadvantages in the managed care system. A third disadvantage in the managed care system is that managed care plans have little or no experience with certain types of disabilities or with certain types of chronic conditions. And so they're less likely to be able to provide intervention or even to identify medical complications in an appropriate way. And again, if we go back to the second one where the physician's receiving an incentive not to send you on to a specialist, and he or she decides to treat you for the condition, that's not to the patient's advantage. But it's not uncommon to come across, again, physicians who don't have a specialty. And again, if you're limited in the physicians within your geographical area who may have a specialty that you're in need of and it's not available, and then you have to go outside of the network, and then you have to go outside of your geographical region even to find that specialist. That's a disadvantage of the managed care system. A fourth disadvantage of the managed care system is that even when that system has specialists to deal with certain conditions, there may be a shortage in the number of specialists who deal with the condition, and in turn what happens to the patient is that reduced timeliness of treatment, and it creates a long waiting period for appointments and between appointments. So again, another disadvantage if we don't have enough specialists familiar with the condition and those specialists belonging to the network. And we know that with certain disabling conditions, you can't just wait until you can get an appointment. You need to get in and you need to see the physician. But if if you have to wait 3 months just to get an appointment, that's going to create some major complications. And then if you can't afford to go outside of the network and pay another physician to get in. So that's a disadvantage. Is not enough specialists within the network increases the wait time for you to get in and see somebody and to be treated. The fifth disadvantage is that there are certain conditions you have some leeway on, but typically as a patient or as a consumer, you don't get to choose the specialist you will see. And sometimes you don't get to choose your primary care physician. You're assigned, once you join the plan or the network, you're assigned a primary care physician. And you don't have a choice in who you get to see. Another disadvantage. A sixth disadvantage, and this is the last disadvantage on the managed care, is that managed care plans limit the amount of visits per year. Okay? And again, we know this is a big disadvantage to someone with a chronic condition or someone with a disability. And if you get 6 visits for a specific condition a year, and you have an episode, and you use up all 6 early within that planned year, then that means you're going to have to foot the bill when you need to go in again. So that's a major disadvantage to people with chronic conditions and people with disabilities is, you get a limited number of visits. And once you've used up those visits, then you're on your own. Okay. So in that sense, managed care is not user-friendly to individuals with chronic conditions or disabilities. Okay. Now, what are some of the disadvantages when we look at privatization? Well, again, remember we define privatization as someone within the private sector administering public service delivery for medical care. Okay, so if we, for example, go ahead and say we're going to privatize Medicare and Medicaid, okay, who controls that? From the public perspective, there's a lack. The first disadvantage is there's a lack of control once we privatize publicly administered health care programs. Okay? And we know, we see this discussion, it creeps around, every 4 years. Okay, for some reason, I don't know why, what that timeline is at 4 years. Okay, but yeah, okay, politically it creeps around every 4 years, right? That there is some discussion about should we privatize, the Medicaid and the Medicare system, and now we're even talking about should we privatize Social Security. So those discussions come around because of political interests, not necessarily because of advantages to consumers or to patients. But there's a lack of control when we look at privatizing public service delivery. A second disadvantage with privatization is that the services will become very expensive. Now, we talk about privatization in terms of controlling costs. Okay? But if you stop and you think about somebody's going to have to administer it, somebody's going to have to staff it. The type of services that are available within the private sector and what services in the private sector cost. Okay? And you can think about a doctor who would say, well, this is a Medicare patient. I know I'm going to get X amount for this office visit. Whereas in private practice, this physician charges a certain amount for an office visit, and that's what this person gets for an office visit. But if you're a Medicare patient, the doctor's only going to get X amount because it's prescribed and it's set. So it becomes more expensive for that private physician to deliver services, and somebody's going to have to eat the cost. And who typically ends up eating the cost? Okay? It comes back to the consumer. It comes back to the patient. Okay? So it may be a situation where if Medicaid or Medicaid is paying X amount, then you're going to have to pay an additional X amount out of your pocket to cover the difference. Okay? A third disadvantage with privatization is there is a lack of available contractors in the consumer's service area. Okay? We're not saying that physicians go into the field to make money, okay? But we know there's a significant amount of costs involved in healthcare. Okay? And we know in this country, one thing we're experiencing is a shortage of physicians in rural areas. Okay? For some reason, we have difficulties getting physicians to go into rural areas. There's a great need. Okay? But if it's not cost effective, especially when we talk about specialists going into rural areas, they're not going to set up practice in rural areas. Okay? So what happens is the consumer has less choices within that service area and also within that network that's available in the service area. So that's, again, it's a disadvantage to individuals with disabilities living in rural areas. And keep in mind, the majority of the U.S. is still rural. We don't think about it that way. But the majority of citizens live in rural areas. So, again, most people are traveling. They're commuting to receive medical services, and they're definitely traveling to receive specialized medical services. Okay? Another The fourth disadvantage with privatization is that fragmentation of services. Okay, if you think about where you would need to go to see a general practitioner, where you would need to go to see a specialist, which hospital then you would have to go to, and if there's not a network available, again, the services are not well coordinated. There's not that fluency of communication within the network. So, you may be traveling to 3 different service areas in order to get the services you need. Okay, so there could be a fragmentation of services. The fifth disadvantage is, and this I think is more of a political focus, is it promotes special interest groups. Okay, that 4-year thing. Okay, who is it that wants to privatize Medicaid, Medicare, Social Security? Yeah. So again, the political side of healthcare with privatization tends to creep into the picture more, and that's a major disadvantage, okay? Especially for people with disabilities. For some reason, you have to fight to get on the radar of politicians, and you have to fight to stay on the radar of politicians. And if you're not the focus, if you're not on the radar, then your interests will not be served, but the interests of the special interest group will definitely be served. Okay, and the last disadvantage I want to mention related to privatization is that individuals with disabilities, especially individuals with severe disabilities who require more costly services over an extended period of time, privatization is going to see that as cost prohibitive. We're having to provide services to an individual. These are expensive services. This person is going to need these services over an extended period of time, and they may need these services repeatedly. And that's where privatization is going to say this is cost prohibitive. And when something becomes cost prohibitive in the private sector, regardless of what industry within the private sector we're talking about, what is it that we tend to do within the private sector? We tend to reduce or eliminate the service. So that's a major disadvantage with privatization. Those are just to give you some of the ideas to think about in terms of how managed care and privatization will work, or how it will be disadvantageous to someone with a disability or chronic condition. The next thing I want to do is kind of talk about specific types of disabilities in relation to managed care. And these, again, it's just a sampling. I can't go into every disability or type of disability, but the ones that I selected are types of disabilities where individuals will need long-term care. And there are certain implications for people with disabilities needing long-term care where the managed care system just does not fit well with them. So first, let's take a look at people with spinal cord injuries. Okay. First of all, when we look at managed care for providing services, managed care is based on an acute care model. Okay. Big disadvantage. People with spinal cord injury, that's not all they need is acute care. The managed care said we're looking at short-term goals. People with spinal cord injury, we're looking at long-term functional outcomes. When we talk about rehabilitation care, be it inpatient care, be it hospitalization, be it day hospitals, be it acute, subacute care, people with spinal cord injury, again, will need the long-term care, home care, and community transition. The managed care said, no, this is not what we do. Okay? At one time, a person with a spinal cord injury initially would go into a hospital or into a medical facility, and the minimum amount of time for discharge was at least 3 months. Based on the managed care, because it's an acute model, what's happening now is that typically people are being released at post-injury. They're being released from the hospital 30 days. And that's a big difference. You had a 90-day stay period, now you got a 30-day stay period. But that's the managed care model. It's based on the acute care intervention, and we know that people with spinal cord, you don't get acute care. That's not all that you're in need of. You need long-term intervention. And again, we see differences between people who have sustained injury in terms of quadriplegia and paraplegia. Okay? Quadriplegia, which typically would have been 6 months in hospital stay, has now been drastically reduced to 2 months hospital stay based on the managed care plan. Okay? So significant disservice to people with disabilities by using the managed care system because it's time limited and it's service limited, it's number of visits limited. What about people with traumatic brain injury? They don't fare any better with managed care systems. Again, we know people with traumatic brain injury, if we think about the amount of physical therapy that's going to be needed, we think about the amount of occupational therapy, and then just the general long-term transition needs of someone with traumatic brain injury. According to the managed care model, you're supposed to get better in a specified period of time. You're supposed to maximize within a specified period of time. And clearly people don't. You know, even if we disregard individual variations simply because of the types of injuries we're talking about, people are not going to get better in a short period of time. And what is really needed is a life care planning approach. And managed care does very little around life care planning. Again, it's short-term, it's acute intervention, and it's time limited. So people with traumatic brain injury, they don't fare well with the system. Now, the managed care system has made some strides in moving toward that. But the bottom line still remains, how can the system be both clinically and fiscally feasible? That's the struggle, you know, because we know people with spinal cord injuries, we know people with traumatic brain injuries need long-term intervention. Okay? So on the clinical side, how can we provide services for the amount of time someone needs it, but at the same time be fiscally responsible in terms of the cost containment for this? So, and that's where I think managed health is a major disservice to individuals with disabilities or chronic conditions. In the area of serious mental illnesses, psychiatric intervention, again, and this is probably of all disability groupings, psychiatric disorders within the managed care system is lagging the furthest behind. We see a lot of variation from state to state in terms of what are the health intervention treatment plans for individuals with psychiatric disorders. And what happens is we're seeing a shift where nurse practitioners, where advanced nurse practices, and individuals with master's degrees, not necessarily medical degrees, individuals with master's degrees are now increasingly becoming responsible for intervention services for people with psychiatric disorders. Okay. This is something that's happening within the managed care system. Okay. But then again, if you think about the availability of services within an area, okay, that's not working well for people with psychiatric disorders. But managed care, and these are just three groups where managed care, I think, does the greatest disservice in terms of chronic conditions or disabilities. Within rehab, I know our focus is mainly on the adult population, but we have expanded some toward dealing with families. And it's interesting, too, to kind of look at how children with disabilities fit into the overall managed care system. I just want to zero in a little bit on what happens with children and what are the advantages and disadvantages of children with disabilities in relation to the managed care system. I think in the broadest sense, I can say the major advantage of children with disabilities going through the managed care system is that there is an improvement to general access and coordination of services. Okay. That's not the only positive thing I can really say about managed health care for children with disabilities. There are more disadvantages to managed care for children than there are advantages. One of the major disadvantages of children with disabilities going through the managed care system is that the managed health care system does not take into account developmental sequence over time. Again, keep in mind it's based on adults. Right? And it's assumed that what is going on with an adult with spinal cord injury is the same thing going on with a child with a spinal cord injury. Not so. Okay? Because children are still dealing in general with developmental issues. Okay? They're still dealing in general with not just their physical needs, but the psychological needs. They're still dealing with dependence on family members. And a lot of what goes on with children in healthcare in general, and especially children with disabilities, is the quality and access to services may in part depend on their family resources. Okay. So in that sense, managed care does not really take into account what goes on with children. Managed healthcare engages in what is identified as risk avoidance. And what do we mean by risk avoidance? Well, children with certain types of medical conditions, certain types of disabilities, requiring an enormous amount of care, and keep in mind we're talking children, so that care is going to be over a longer period of time. Okay, so those children, the risk avoidance is that certain programs, certain plans, and for lack of a better way to phrase it, actually discriminate against children with certain types of disabilities. Okay. You pay more for services. The number of visits may be even more limited than children in general would receive. And physicians may not, especially when we're talking in terms of pediatric medicine, may not have the expertise to deal with certain types of disabling conditions or chronic conditions or low incidence condition among children with disabilities. So what happens is that a child may be assigned a primary care physician the same way as an adult is within the managed care system. There is not a specialist or a limited number of specialists available within that managed care system that can deal with or who may be familiar with the condition that this child has. Okay? So now what happens? Where does this child go for services? Typically, the family may have to look outside of the network to get services from a specialist, which means additional costs. So, but, you know, it's just not user-friendly at all to children with disabilities. And to keep it in mind also, because physicians are, they get some type of incentive to not refer, they're not going to refer children any more than they're going to refer adults to see a specialist. Another problem may be there's, because we're dealing with the developmental sequence, there may be a lack of clearly defined clinical standards for certain chronic conditions in terms of what the treatment protocol should be. Especially if it's a rare condition, especially if it's a low incidence condition, and especially if it's something that is new to the medical field. There is no clinical protocol for what the intervention will be. And keep in mind that when we talk about how the number of visits are determined, how costly would it be to provide this service, it's because there's been some medically proven clinical protocol on what type of intervention will work best, how many times a person will need to come in and do A, B, C. Okay? But with a lot of low incidence types of disorders or rare disorders, a lot of clinical trials have not been done. Yeah? So it's undetermined how many visits, how long it will take to receive or achieve some kind of improvement. It's not known. And managed care, again, that's a disadvantage to managed care because they don't know how expensive this is going to be. We're going to guess this is going to cost us a lot of money. And we don't have the clinical protocol to say, well, we know how to figure the formula to determine number of visits, type of specialist this person will need to see, and over time, how long will it take to get some type of improvement. So in that sense, managed care is not advantageous to children or to adults with disabilities. And the next thing I want to mention to you is I have a whole grocery list here of requirements related to managed care plans. And this list is quite long, so what I'm going to do is to kind of skip around on and talk to you a little bit about what are some of these requirements. And keep in mind that some of these requirements are administrative requirements, but they still have impact on the consumer or the patient. There are 16 of these requirements, but we won't do all 16 of them. Okay, so I'll just try and highlight some of the more important ones, or maybe even some of the ambiguous ones in terms of what are the requirements related to managed care plans. And these requirements were established by the American Academy of Family Physicians. And the American Academy of Family Physicians identified these requirements as a living document. Okay, and they said it was a living document simply because these requirements will need to be modified in accordance with, and it was very important that they put this in the new evolutions, okay, in the healthcare market. So I thought, wow, they're being forward-thinking and very innovative here. But this is a living document. It changes because we know if you stop and you think about the number of treatment protocols that are available today compared to 5 years ago, even 2 years ago. So this document is saying, okay, as new evidence comes forth, then physicians will need to be able to make these changes, and managed care systems will have to incorporate and accommodate these changes for the physician as well as for the patient within that network. Okay. So I'll just go over a few of these with you and try to expand a little bit on what these are. So these are the requirements related to managed care plans, and these are the programs and points of service plans related to physicians and patients within the managed care system. Okay, the first one simply states that managed care plans should provide sufficient information about plan terms and conditions to allow prospective enrollees and patients to make informed enrollment decisions. Now, here enrollees refer to the physicians. Okay, because the physicians have to also enroll into the plan to become a part of the network, and then their patients enroll into that network or that plan as well. So number one is basically saying that the physician to make a decision of whether or not to participate in this plan will have to be given sufficient information up front. And the patient, when you're choosing your insurance plan, and you think about the information you receive for your insurance plans, and you're comparing A to B, B to C, and et cetera, and you think about the information you receive, and we like it nice and short and summarized for us, so we won't have to read through all of that stuff. But the physician must also receive that type of information to make an informed choice about enrollment, just as the patient has to receive that information to make an informed choice about enrolling in that network and what physicians are also in that network. Because that becomes critical if you really stop and you think about it. With most plans, you enroll for a year, and then you get your renewal period. You can either keep the plan you have or change during that new enrollment period. But think about trying to make a choice without having just the basic essential information, of who the physicians are within that network. And you think in terms of medical condition. And you think in terms of who are the specialists, or how many specialists may be a part of that group. And you may pick it based simply on the number of specialists available, because that increases the probability that you may get a timely appointment, that you actually get in to see somebody. So having just some of the basic information up front is one of the major requirements in terms of the point of service. Okay. Let's skip to number 3. And number 3 says that managed care plans should demonstrate that they can provide sufficient access to physicians and other service providers so that all covered medical services are provided in a timely fashion. Critically important to someone with a disability or chronic condition. Okay. Now, we know they're not going to say, if you come in, if you enroll in this program, you can see your physician in a week and you can see a specialist in a week. It's not going to be that specific. But they have to demonstrate that timeliness of service is something that will occur with this plan. And we know, again, for people with disabilities, people with a chronic condition, timeliness is crucial. Now, we can't wait and think it's going to get better. You know, if you have to get in to see the specialist, you have to get in to see the specialist. So that's something as a point of service that managed care plans will have to be able to illustrate to enrollees, the physician, as well as enrollees being the patient. Okay. Let's see. Let's skip to number 5. And number 5 says that managed care plans should have sufficient financial reserves to ensure proper and timely payment of covered services. Gosh, what does this have to do with people with disabilities? Why do we have to ensure that there's money that the doctor will be paid for the services? Okay, just think about that one. What happens if Medicaid or Medicare does not make timely payments to the physician? And if that doctor or that physician has a disproportionate number of patients who are Medicare or Medicaid patients, what do you think might happen? Because the physician is getting, it's slow pay. Right? But in the meantime, this is more of an administrative aspect that trickles down to the consumer. Right? If I can't pay my bills as a physician, I can't meet my payroll, I can't pay my office rent, I can't pay for all this equipment in this office because it takes Medicaid 3 months to pay me from the patients I saw earlier. What impact will this have on me delivering services? I may not stay in business. And this becomes even more crucial in service areas where we have a limited number of physicians. Something to think about. Let's see, what's another good one here? Let's look at number 6. Number 6 says that managed care plans should establish a mechanism by which physicians enrolled with the plan can provide input into the plan's medical policies. Boy, wouldn't we love that as a patient? Has actual input on the policies of, but this is simply saying, and this has great implications because as a medical provider, you're telling me I'm responsible for the service delivery part of it, and whatever rules or policies are specified, I have to abide by them, but I have no input in them. And again, think about this in terms of what privatization may mean, where a physician may have much less input into the policy making. Okay. So again, if I get limited input, but I still have to be the one who delivered a service or to enforce the policy, and it's not advantageous to my patient, should I stay within this network? Could create problems for service delivery for patients when your physician pull out of a network in the middle of the year. Okay. And again, especially if in the beginning you have limited choices of access because of the service area or where you're located. Okay. Let's look at number 8. And number 8 says, in regard to physician enrollment, managed care plans must provide physicians with the reason for disenrollment, the right to appeal the disenrollment decision, and sufficient notice of disenrollment to allow the orderly transfer of patient care. It sounds as if that the network, the managed care network, can boot out a physician. What if that happens to you in the middle of a year? But this is saying, yeah, that can occur, but the physician has a right to appeal. It has to know why it happened, and there has to be sufficient time. You can't just strand patients. There has to be sufficient time so that there has to be a grace period in there where the physician continues as an enrollee within that network until those patients can be transferred to someone else within the network. Okay. Again, it goes back to continuity of care and timeliness of services. It's a very important one to think about. Again, like I said, with chronic conditions, you can't just get booted out of a system in the middle of the year and just wait to maybe an overburdened system already find room for you. Okay? So it has to allow for that physician to find time to find someone else to take over that patient caseload. Okay? And physicians can be disenrolled for several different reasons, but the reason has to be clear, and it has to be documented that disenrollment was the right thing to do. Okay? But again, this is one of those where a patient has no choice. We don't have the choice of if our service provider is disenrolled, and we're kind of stranded until we can find somebody or somebody to take that case or to become our new physician. So, okay. Let's take a look at number 10. Number 10 states, utilization review programs must respond to requests for authorization of services within 2 business days. Boy, wouldn't we love that? Okay. What do you think this is referring to? Well, basically, and we all may have a situation where we've used up our number of visits, we've exceeded the quota in terms of the premiums, what the premiums will pay for, but with a chronic condition, something happened, okay? And even though you have no more visits left, or you've exceeded your number, a physician can request authorization for an exception. And because timeliness is important in that situation, that's why that little specified period of 2 business days is indicated. Okay? Because, like I said, you can't just wait until one with an MBA decides you need to get in to see your specialist, or that you can't see your specialist now because you've used up all your allotted time. So it has to, that special request or that authorization has to occur within a reasonable time period, here specified as 2 business days. Okay, because timeliness of service becomes a crucial issue. Okay. Let's take a look at one more. And let's take a look at number 11. Okay. Whenever practical, potential enrollees should have a choice of a health care plan, at least one of which should include a point of service option. Okay. And remember earlier we defined a point of service when we had those 3 acronyms of the 3 different types of managed care systems. The point of service being that you're assigned to a primary care physician within the network. And that's all this is saying, is that as an enrollee, that plan, no plan should take place without you having a point of entry, having basically a general practitioner. Okay? Because if you don't have that, and the system requires that you have a referral from the general practitioner to see a specialist, you can't skip the GP in order to say, I'll just go directly in and see the specialist, okay? Because the system itself can deny you doing that, okay? So, but the plan must say, no, you've got to have one, and we have to make one available to you, okay? And again, these are just some general examples of the requirements set forth for managed care plans. The last thing I want to kind of introduce to you is a more like raise a question. And this question deals with what are some of the future implications for managed care in relation to people with disabilities. One big issue will continue to be that of accountability. We all have to be accountable no matter what system we're dealing with. We have to be accountable. So if we talk about privatization of managed care, how do we measure accountability? How do we ensure quality services? How do we make sure that consumers, in this case patients, have some recourse within a managed care system that's now controlled by the private sector? So one big issue for the future is we have to look at the issue of accountability. A second issue we have to look at is that of case management. And we know that privatization of private sector, they kind of ushered in this whole case management idea, and then the public sector kind of adopted case management. But we have to look at rehabilitation counselors, where you continue to be counselors or where you become case managers in a system that becomes privatized. And this may be one that is a little touchy, because when we say a counselor, we perceive ourselves a certain way. When we say case managers, we perceive something else. But if we move to privatization and you become case managers as opposed to counselors, then you'll find yourself being more of a liaison between rehabilitation teams or agencies, and not necessarily a counselor. So that's the second question we have to consider when we talk about implications for the future. Will you be counselors or will you be case managers? A third consideration for the future is, will we continue to have our primary focus on individual empowerment? We know that within rehabilitation, we've given a lot of focus to consumer empowerment. With privatization, will this continue to be a primary focus coming from rehabilitation? Will consumer empowerment or individual empowerment be in the forefront? A fourth consideration of privatization would be, will we see a shrinkage in the number of counselors working in the public sector? Will we continue to need rehabilitation counselors in the sense that we're thinking of rehabilitation counselors today? So, and that's a question not only for service delivery, but also for training programs. So, will we need less counselors in the future? That's a question. And the last question for future implications I think we would have to look at is the role of the counselor. Will you continue to have that traditional role where you're the service coordinator, you're the counselor, and you're the advocate for consumers? Or will you now be required to move more into specialized areas of expertise? If you think about training right now, we say we train generalists in rehabilitation. So given movement toward privatization in managed care, will rehabilitation counselors now be required not just to be a counselor, but we have to have within that a specialization? Will that be a requirement? So that is something to think about. And I'll just conclude by saying I think that there are two general or broad-based questions I would like for you to ask yourself as you think about privatization and managed care. And I'll just stick these on the overhead. And these two questions, the first one being, what do you see as the next direction for managed care? And I'd like for you to think about that in terms of professionalization. And the second question is, how will this direction impact persons with disabilities and those with severe disabilities? So hopefully this discussion didn't turn you off of managed care, but at least raised some questions about the utility of managed care in relation to persons with disabilities and to persons with severe disabilities. So just something to think about. So food for thought. And I think for sure that this discussion around managed care is something that's going to be ongoing. The question of privatization will be ongoing and revisited in the future as well. So thank you for your attention and your time, and think about how you can work within the system, because managed care is here. It's not going anywhere. But think about how you can make sure this is advantageous to the clientele you're serving. Thank you.